Hi, my name is Tiffany Lu. I'm a general internal medicine physician and addiction medicine specialist practicing in the Bronx, New York. I would like to talk to you today about determining the if and how of tapering and discontinuing buprenorphine treatment. Let's start with a case. Mr. Jones is a 30-year-old male with opioid use disorder who presents to see you in the office for follow-up. He started buprenorphine treatment 6 months ago for prescription opioid use that escalated to daily heroin and fentanyl use. He has been taking sublingual buprenorphine 24 milligrams daily, and he's achieved success with interval abstinence from non-prescribed opioid use. It's exciting and stressful for him to be expecting a first baby with his partner. In this context, he feels a lot of pressure to stop taking his buprenorphine. And he's asking you, Doc, when do I stop this medication? It turns out that this is a very common scenario that we encounter in office-based buprenorphine treatment. Clinical guidelines, including that from SAMHSA TIPS 63, recommend that patients continue buprenorphine treatment for as long as they benefit from it and wish to continue it. We recognize that we don't have empirical data on the optimal duration of buprenorphine treatment for opioid use disorder. We do know, though, a few things about the duration of buprenorphine treatment and its association with adverse outcomes. For one, buprenorphine detoxification or early tapering at the initiation stabilization period of buprenorphine treatment has been shown to be associated with decreased retention and treatment altogether and a very high likelihood for returning to non-prescribed opioid use. In fact, we know that retention in office-based buprenorphine treatment can be as low as 50% at 6 months. So even for those for whom we continue buprenorphine treatment, 1 out of 2 patients may not make it to 6 months of buprenorphine treatment. And among those who remain in treatment even after 12 months of accessing and taking buprenorphine altogether, treatment discontinuation can be associated with a high risk of acute care service utilization, such as emergency department visits and inpatient hospitalizations, as well as opioid-related overdose within 6 months. So, why do patients discontinue buprenorphine treatment despite the negative outcomes associated with it? Well, we know there are 4 major reasons as to why patients do this. Number 1 is insufficient medication dosing. One study found that a dose of 16 milligrams daily was associated with at least a 20% higher risk of treatment discontinuation within 6 months of treatment compared to those who received a dose of 24 milligrams daily. And this is especially relevant in the age of high-potency synthetic opioid use. Studies have also shown that inflexible program policies or expectations are associated with patient-directed discharge from buprenorphine treatment. And one qualitative study details how patients perceived conflicts with program staff as well as administrative or involuntary discharge were the most common reasons why they left office-based buprenorphine treatment within 6 months. Other studies have really highlighted the amount of medication stigma that is associated with patients discontinuing buprenorphine treatment. This quote is particularly salient. "I am clean and sober, but I'm not necessarily free." It demonstrates how patients have concerns about physical dependence to an opioid, despite it being a prescribed medication for opioid use disorder treatment, and that stigma around the fact that they're taking medications are common themes for patients in even long-term treatment. Finally, there is actually a subsegment of patients who are able to achieve clinically supported tapers, but what we know is that this is a very tiny percentage of patients. One study of a large cohort of patients in office-based buprenorphine treatment found that only 8% of their cohort successfully achieved buprenorphine tapers when they looked back at 12 years of program data. So in essence, what we do know is that most patients need adequate dosing to stay on buprenorphine treatment, and that our program policies and expectations should be individualized and flexible. Medication stigma needs to be addressed, and for the subset of patients who desire a clinically supported taper, it is possible. Clinically, we can apply this lens to the when of tapering being considered. So I think we can break this down into 3 key parts. One is we need to consider the length of stability that a patient has had in buprenorphine treatment. And in general, the longer, the better. And that stability is very much hand in hand with the success that they have had in reaching their opioid use disorder treatment goals. And for patients, this might mean abstinence or minimal use of non-prescribed opioids. So for the individual who's had a long period of stability in buprenorphine treatment, having a success with getting to their goals, if they are being strongly motivated to taper and discontinue, and that they've actually built adequate psychosocial supports, this would be somebody we should be able to talk openly about buprenorphine tapering and discontinuation under clinical supervision. How can we do this with clinical supervision? The first part is this is a slow process. We need to set expectations with our patients that they will physically feel a lot better if we take it slowly over several months. Clinically, we can do this by reducing the daily dose of sublingual buprenorphine by no more than 20 to 25% per month. So for example, for a patient who's taking 24 milligrams, we can gradually reduce this down to 20 milligrams over the course of 1 month. Next, we need to talk to patients about how to optimize adjunctive medications and psychosocial support. Anxiety around anticipated withdrawal or experienced withdrawal symptoms can be very unsettling for patients undergoing a planned taper. Prescribing adjunctive medications such as alpha-2 agonists for withdrawal-related anxiety can be very important in the tapering process. Helping the patient name, anticipate, and manage potential triggers for cravings and otherwise negative withdrawal experiences during this tapering period can also be discussed during our office visits. And finally, we need to be clear with patients that this is, after all, an individualized and harm reduction approach that we are taking. And so this means that whenever a tapering dose is not going as well as planned, we can halt that process and revisit altogether. For patients who have successfully tapered off, we should leave the door open for them to return and resume medication treatment at any time. And it's also important for us to offer our visits for follow-up to provide ongoing support, even if they're not taking medications any longer. There is an emerging approach to using extended release buprenorphine injections to help patients discontinue sublingual buprenorphine. This is a small case series that we have found in clinical practice to be relevant. So in this case series of 3 patients who have been taking sublingual buprenorphine, they found it difficult to taper down beyond 2 to 6 milligrams daily. They experienced prolonged opioid withdrawal symptoms when trying to taper on their own. So in each of these cases, patients received 1 dose of extended release buprenorphine, 100 milligrams, which represents an off-label use of the name brand Sublocade, and subsequently achieved successful discontinuation of sublingual buprenorphine. Although this case series is small, it definitely reflects the emerging clinical practices around the use of extended release buprenorphine, especially in the case of helping people taper off successfully. The only caveats about this case series is that 2 of the 3 patients did not meet criteria for opioid use disorder. Let's come back to our case of Mr. Jones. I think the message that we need to be clear about with patients who are inquiring about tapering is that tapering can be done, and it should be done slowly when the timing is right for you. We need to take everything we have learned about our evidence so far and mold this into a strength-based approach when we're speaking with patients. And so for Mr. Jones, is to affirm his treatment progress so far over the last 6 months. We also need to recognize medication stigma and its role in patients' tapering questions. So in our visits, we need to explore the stigma by asking about the patient's beliefs of medications for opioid use disorder treatment. Practically, we need to confirm that the medication is, after all, accessible. So affordability of sublingual buprenorphine for treatment is something that we need to double check is not a reason why the patient is asking about tapering and discontinuing. Then we need to offer some concrete options. For the patient who is inquiring, we do need to talk about how we might do this when the time is right. So offering the gradual taper of sublingual buprenorphine, for example, from 24 milligrams to 20 milligrams, which is a 20 to 25% dose reduction over 1 month, would be appropriate for Mr. Jones, and to also offer and discuss subcutaneous formulation alternatives to sublingual buprenorphine. So in this case, Mr. Jones ends the visit by thanking you for listening to him. He felt heard, and he wants to defer the idea of tapering his sublingual buprenorphine at this time. You leave the door open and agree to discuss again at his next follow-up visit in 1 month.